The OrthoPAC podcast, hosted by Sam Dyer, Chuck Dowell, and Miles Gilbreth. Welcome to the OrthoPAC podcast, where we attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, listeners. Today we have another panel discussion with Chuck and Miles, and we're talking about when can we return to sports. Can you return to sports after an injury? Can you return to sports and be active or run with knee osteoarthritis? So we thought this would be a good topic to share with the listeners and talk about some different examples. Why don't we start with cortisone injections? I know that PAs that work in orthopedics at some point will give a cortisone injection. And I guess it also depends on what the diagnosis is, but let's just say arthritis and maybe a synovitis and someone got an injection. When can they get back to training for their marathon?
So I kind of have the same script that I say to patients every time after I give a knee injection. I always tell them to take it easy tonight. There is the possibility of a steroid flare tomorrow or the next day where the pain is actually increased above baseline. And I tell them that if you're too active tonight while you're numb, you're sure to pay the piper tomorrow. You get to cuss me for 24 hours and let it start to calm down. But once the knee pain starts to calm down, I pretty much let people return to what activities they want to do.
Yeah, I have a very similar. I usually tell people no extensive activities for 72 hours. They can go back to their daily life, do their errands and do their normal activities, but ideally give it 72 hours to allow the steroids to kick in and work. And then as it starts to feel better within 3 to 5 days, they can gradually get back to their activities. And similar to Miles, I have the same conversation regarding steroid flare and just the same conversation saying, hey, if you go out and are active on this, you're negating the facts of the anti-inflammatory properties of the cortisone and potentially not getting as good success out of the injection. So that's normally what I tell them.
Great. Well, all you guys patients can come see me because mine never have pain. I'm just kidding. I agree completely. 72 hours. And, I've had different kind of time frames after the injections where things work. Some people, it's like, the local, when they're walking out of the office, "Oh, this was great." But it seems to me that depending on where you're giving the injection, and this is anecdotal, but knee injections, like you said, usually 3 days to a week. Shoulder injections, in my experience, take longer, and I don't know why. It's usually up to a week before they really kick in. I've even had some people at 2 weeks where it works. Other injections, other areas, and I guess I'm kind of jumping the gun a little bit, but like lateral epicondylitis, dequervains, whatever, they work faster. What do you guys take on that?
Yeah, I would agree with you. I think it depends on what I'm injecting. I feel like subacromial space responds quite similarly to interarticular knee injections, but sometimes my glenohumeral injections may take a little bit longer. But again, I also think, like you said, it depends on what I'm treating. I've noticed people that come in with more of just, a flares from arthritis tend to get the reaction quicker than somebody that comes in with more of a gouty or pseudo-gouty type reaction that could take longer for that kind of cytokine change and that, anti-inflammatory effect of the injection to take place.
Yeah, I unfortunately don't get to see my patients back, just given the nature of my practice. And so I don't get many complications after injections, knock on wood. But I do think that definitely depends from the times that I do get to see patients back. It depends on the location. And I agree that I think that trochanteric bursitis, lateral epicondylitis, dequervains, TFCC, even things that are more superficial do seem to take a little bit quicker. I also use neuropin instead of lidocaine and marcaine, so my patients are more likely going to get a longer anesthetic effect. And so I remind them.
Wait a second. What did you say you use? Run that by me again.
Ropivacaine, neuropin.
Oh, neuropin. Okay, ropivacaine. All right, you throw the cane on it, neuropin. I was like, what's that?
Right. Yeah, it's just, we have conversations at conference and it's just less chondrotoxic, longer sedative. It's not as quick to kick in. And so I still use lidocaine, say for a knee aspiration to numb up my approach path. But I do definitely remind those patients that they're going to be numb for 8 to 10 hours and not think that is the steroid doing its job, but that is the anesthetic doing its job.
Yeah. Did you guys, it seems to me there was an article at some point in years past, and I don't know, I can't really put my finger on where it came from or what it was, but Marcaine had more of a soft tissue irritability than lidocaine. And I'm not familiar with the one you're using, Miles. Do you guys have any experience with that? Like intra-articular, no big deal, but extra-articular structures, Marcaine can be more irritating. Have you ever heard of that?
I actually I haven't.
Maybe it was a dream. I don't know, but I really remember that from somewhere, and I don't know. I'll have to look it up. We'll have to talk about it some other time. But so returning to activities, I think our consensus would be like after an injection, joints and stuff, at least 3 days to a week. If you have the marathon runners, I don't know your experience, guys, but runners are notorious that, if they can't run, you're taking away their religion, their birthday, and their firstborn child. I got to run. I got to run. I got to run. It's a mentality. It's a personality. And these are all my opinions, but what do you think? Have you seen that? Like, I got to get back. No matter what, I got to, run tomorrow. What do you tell those folks?
Yeah, I think when we were talking about doing this topic, this is kind of the scenario I thought about. I think most people that come in that are in an athletic population, and I'm lucky enough to live in Colorado where a lot of people want to get back to outdoor athletic activities. The first question they always ask is, when can I get back to my normal activities? And depending on what we're treating, I think a gradual progression back into activities is probably makes more sense than, a marathon runner that comes in with an acute arthritic flare and is training for their marathon. And as soon as their knee starts to feel better, they get back to, 40, 50 miles a week. I think that's just going to increase, their inflammatory response and possibly allow the injection to work for a much shorter period of time. So I try to encourage them that they can get back to those activities, but maybe gradually wean back into them to allow maybe full, beneficial effects of the injection. And that tends to allow it to last longer and do better. But I think it's very individualized. It's asking them when the race is, trying to time everything based upon when the race is or when their activity is or when their next game is, because I think that's an important question to ask anybody. What do you have coming up? What's important? Because if their race is a month away, then maybe they can gradually progress back into those activities, or the running activities and not have a significant step off or loss. But if the race is 1 week away, then maybe they jump right back into their high mileage volume, knowing that the injection will probably wear off after the race.
Yeah, if the race is a week away, it might be a good time to talk about tapering too.
Correct. Yeah.
On a different standpoint.
Yeah.
When it comes to runners and knee arthritis, obviously this is completely anecdotal. I feel as though I see some of the most advanced but well-tolerated arthritis in these high-level runners. It poses the question of what protective effect does that activity have on their pain perception? Because I'll have people come in that are completely bone on bone, tricompartmental arthritis, and their knee sort of bothers them a little bit. And so I find that anecdotal finding of advanced arthritis that is completely well-tolerated runners to be overrepresented in that population.
One word, endorphins, baby, endorphins. Yeah. So I've found it to be difficult. Compliance is a big thing with whatever you do. And I kind of would take it a step further with what Chuck was saying, is it the championship game of the year? And, I've been playing for the last 4 years, preparing. Can I safely get back? And I think that kind of gets into the thing, pain tolerance versus what is safe for you, what's going to cause you long-term harm. And so that's kind of how I look at it when it comes to it. If you're an eighth grader or seventh grader or whatever, and you've been playing for 2 weeks and you're anxious to get back is one thing. But if you're at the end of your high school career, you're in the state championship game, or you're on some national level doing whatever, pickleball or something, it just depends. And so it's a case by case basis. But yeah, I agree with what you guys are saying. You have to have that conversation and say, well, if you do this is a potential outcome. And as long as we're all aware of it, then, here's what we'll do. So that's kind of how I've always approached it. Let's talk some more. We talked about cortisone injections. Let's talk about how about activities like post-operative. Listeners, please follow up next week for a continued discussion on return after surgical procedures. When can I return to sports?